Hello again. Welcome to another episode of the Global Neonatal Podcast. Bozu, how are you doing today?
I'm good. How are you?
I'm good. I'm good. As always, excited for our interview conversations. We meet such amazing people who do amazing work. So I'm very excited about our conversation today.
Oh, yeah, same. Super excited to be speaking with Dr. Rajesh, who was on our Newborn Toolkit webinar recently, talking about leadership in fast progressing countries. So, super psyched to hear deeper about his quality improvement work. And yeah, just glad to be here again.
Yes. Dr. Rajesh, we're so happy to have you on the podcast. In the interest of time, we're going to just give a very brief introduction and we'll put your more extensive bio on our podcast show notes. So
Thank
today
you.
we are honored to welcome Dr. Rajesh Mehta to the show. Dr. Mehta is currently an adjunct professor at the Public Health Foundation of India and the Indian Institutes of Public Health, where he supports academic programs and research in maternal, newborn, child, and adolescent health. He also chairs the International Pediatric Association's Working Group for Quality Improvement and Patient Safety and consults with the WHO on global child health initiatives. With decades of experience, including his role as regional advisor for the WHO Southeast Asia Regional Office, Dr. Mehta has been a driving force in improving healthcare quality and equity across nations. We're thrilled to have him today. Dr. Rajesh, welcome to the podcast.
Thank you. It's my pleasure to be part of this conversation. I hope we are able to, recall and present to the people who may be interested to understand how newborn care, goes in low middle income countries. And I am happy to be with you. Thank you.
Great. Now, we always like to start on the podcast, we call it origin stories. So we would love
Okay.
to start by hearing a little bit about your journey. What prompted you to do pediatrics? And can you tell us a little bit about how your career unfolded? We mentioned there that you've done so many different things across your career. So just tell us a little bit about what prompted you to do pediatrics and how your career unfolded over the years.
Yeah, it looks like history. I am of previous generation, as you would be able to imagine. I completed my MBBS, which is the basic medical degree from Delhi University. I was lucky to get into a prestigious institution called Maulana Azad Medical College in New Delhi, and its alumni have actually made name for themselves as well as for the institution. So I actually, after completing my graduation, we had to make a choice to get into post graduation. And there was an all India entrance examination even those days. This was 1981. And those days pediatrics was opted by the toppers who secured good ranks in MBBS would aim to get into pediatrics. My own personal motivation was, I was kind of fond of children, and many of my peers, I could realize that they can't withstand even a crying child, whereas I was quite comfortable, and of course I was keeping a good rank, so I thought, let me give a shot to pediatrics, and that's how I entered pediatrics. So 83 I completed my master's program, 1983. And pediatrics at that time in undergrad was not a separate subject. It was part of internal medicine, and it wasn't even a subsidiary in examinations, assessment, mechanisms of MBBS. And at the best, we would have a spot case in clinical examination in final year and a short note and written examination of pediatrics. That was pediatrics for us in MBBS. So all the specialized skill set which I acquired was through my master's degree of 2 years at that time. And then from there, I continued to work in clinical settings. But I was a little bit, fortunate to actually experience my pediatrics clinical side also from primary level to tertiary level. So I had postings in just remote small hospitals as well, and finally I landed up in a tertiary hospital which is again a premier institute in India. In Delhi, Safdarjung Hospital, a 1,500 bed public hospital, and a big pediatric department, and a neonatology unit. While during our MD pediatrics, neonatology was not a specialty at that time. It was essential part of training, but it had not required that specialty status by them. But subsequently, a few years later, people had started doing fellowships, and then DM, postdoctoral program, was introduced in India. And therefore, this is how neonatology as an education, evolved. The Pediatric Academy, Indian Academy of Pediatrics, actually was formed in way back in 1968. And Neonatal Forum, the National Neonatal Professional Association, was formed in 1980. And but NNF, the famous NNF, or National Neonatology Forum of India, actually helped evolve the government, the public program of newborn care, with a constant, technical support coming from the professionals. So I was part of that, scenario in my clinical career of around 28 years before I moved to WHO. First in India country office, where I spent about 4.5 years, and then subsequent 10-11 years I spent in the regional office. So initially India, and then 11 countries of Southeast Asia, including India, through my regional office. So I have watched very closely the evolution of newborn care in India and in the region. And therefore, it gives me an opportunity to actually, rewind and see where we excelled and where we could have done better. So that's my, association with child health and neonatology. 28 years in clinical side, and about 15-16 years in WHO as public health kind of programming, and then now continue to teach and research a little bit after retirement. That's me.
Just wow. I don't even know where to start from on what to unpack from what you've shared, but it sounds like you have lots of experience and lots of learnings. So I'm sure our listeners would be very happy to hear from you and learn from you. So you touched on the evolution of newborn care towards neonatal mortality rate in India at the end of your descriptive story. So could you please share with us your role in WHO linked to the evolution of the newborn care and the neonatal mortality rate in India? And how do you think other LMIC countries can learn from fast progressing countries like India?
So, as I was mentioning, neonatology first came to the profession. There was hardly any newborn program in the national, maternal child health programs in the country. Although, we had started well by, India launched family planning program quite soon after independence. 1951 is the National Family Planning Program, which emerged. And subsequently, the next biggest program was EPI, Expanded Program of Immunization, in 1971. In all of the, public health programming, maternal child health was receiving, attention, but it remained very rudimentary, kind of essential package of primary health care as was defined by Alma-Ata. But it hadn't been, given to so much of priority which it deserved. So neonatology, for example, the first neonatal unit actually emerged in a postgraduate institute in north of India in 1968. So that was the time when in fact it was 1968. Yes. These are a couple of professionals who had exposure to neonatology because they visited UK, and one of them, I think, USA. They came back And then WHO supported at that time with a 2 weeks training, and a neonatal unit was started in a medical school, which was postgraduate specialty hospital. That was the first neonatal care unit. And then after that, it took some while neonatal care emerged as important component of NCH programs. For example, the first national program which recognized mother and child issues was child survival and safe motherhood program, 1992 to 1997. There we had a very structured first time, CSSM, as we called it, child survival and safe motherhood. So lot of dependence at those days was on traditional birth attendants. There were not many skilled midwives or nurses to deliver women. So much emphasis was on TBAs, which were there in the community. NNF, as I said, was established in 1980, and soon after they had a perinatal committee, and they had recommended that essential newborn care should be introduced. But it took the government about a decade. So only in CSSM in 1992, or 10 years later, essential newborn care actually came in as an intervention package. So therefore, trainings in due, appropriate methodology started for medical officers, nurses, and TBAs on essential newborn care, and a very rudimentary training on resuscitation, for example. So by then, professionals had come to say that for newborn care, we need essential care for all babies. Okay, right from birth, and thereafter, all babies, whether healthy or sick, small or good size, essential care for all newborns. But they also said that additional care would be required for small babies, low birth weight and preterm. And of course, some more care would be required for babies who become sick or have complications. So clearly, there was understanding that essential care, special care for small babies and for sick babies. And then the profession informed the government saying that, we need to provide care at home through community approaches, through home-based care, and also then in facilities where small babies and sick babies must be managed. So those were the days when even deliveries were happening at home, most of them. So even facility-based care at the time of delivery was not followed or not available. So institutional deliveries were very few. So the trajectory which was followed, that initially we started with ENC, essential newborn care, and then a little bit complex facility-based care for level 1, level 2 for smaller hospitals in the district settings, and meanwhile some intensive care units had also started emerging. So there was a phase when the NNF was recommending that we must make available even intensive care for 10-15% of babies who need that care. But since resources are not there are not enough facilities, there's not enough professional expertise, can we do a regionalized model that in a region there is at least one neonatal intensive care unit, and it is surrounded by several level 2 care units. So that kind of approach emerged. So when I look back how the other countries or developed world has also progressed, it's been a similar historical trend that initially the lives were saved by a public health approach, community oriented essential care approach, because the understanding of newborn care was not much in the first phase. So in low middle income countries like India and neighborhood, that was the situation with which they started. And then technology evolved, level 2 care emerged, and level 3 or intensive care also then continued. So that's the evolution of newborn care in India as well. So maybe we'll have opportunity to say how from one unit of level 2 care. So I told you way back late 60s, the first intensive care in the medical school. Some more of such units started, but the first actually district level intervention through facility based care actually in India happened in late 80s, 1980s, in a district in West Bengal. So it was more of a pilot, a model to demonstrate that without very high tech equipment, lives can be saved, newborns who are sick or have complication, in the hands of a pediatrician or trained medical officers and some nurses in a level 2 unit in a district setting. So proof of principle actually was established and this experience was available. And then, we had some beginning from the government side, some state governments, with the support of UNICEF and some partners initially. They started with district level newborn care, level 2 care, which was, labeled as special newborn care units. So the famous SNCUs, district level 2 care units, with a standardized model, started in the year, for example, 2000. So the first was in 80s, but it took about 10 years to actually catch up and start neonatal care units in the districts, in the district level. And then, after initial demonstration that such units can be operationalized, the government actually then quickly replicated. And very soon, from 2000 until now, in these 2.5 decades, we now have more than 1,000 such units. So it's a long, historical journey. The first district level unit in late 80s, published in early 90s, and late 90s, early 2000, we started with replicating this model, SNCUs, and it took another 20 years to scale to more than 1,000 units. So that's the story within India, and a lot of work was done, and we know how it was scaled up. We have studied and we have actually documented that what are the facilitating factors which actually led to this. And then, this model was exported to neighborhood countries. And also it was taken by partners to some countries in Africa. So it's important to understand that if experiences are shared in time, and that some documented success becomes a cross-learning mechanism, countries can benefit from each other. And the South-South dialogue and cooperation was very important. For example, there is a association for a local formation of countries in South Asia, which is called SAARC. SAARC is South Asia Association of Regional Cooperation, and there are 8 countries. And there is a SAARC Foundation Fund which was made available by Indian donation. And this model of facility-based newborn care district level SNCUs was actually provided to Afghanistan, Bangladesh, Nepal, Sri Lanka, Maldives. So that's how some of these countries actually got formal replication support to undertake district level newborn care programming. And of course, then I think it was USAID with whose help the model was transplanted in some countries in Africa. So that's the learning from LMICs, that if the government shows leadership and actually provides along with the policy a dedicated budget line, and much of this was Government of India money. Partner money was initially useful when we were trying to do a demonstration exercise, that one unit 10 years back, then how do we replicate? And the government was waiting when we could demonstrate in 5-10 units, 5-10 districts, and then they picked up. So technical support continued to come from National Neonatology Forum, but also from WHO, UNICEF, and other agencies. But the government liked the whole stuff. So they had clear budgetary lines. They had clear, commitment to hire people. 1 pediatrician, 4 doctors, 9 nurses, or 12 nurses, sometimes for each unit. Essential equipment, continuous supplies, then data and information management, close monitoring. So all the health system, readiness was demonstrated by this very consistent approach. But we still have challenges. If you allow me to continue, the challenges are there.
Go right ahead.
So infrastructure adequacy is still not there. We have more than 1,000 units. At all districts have at least 1 unit. And the global target was, until 2025 to achieve 80% districts at least have 1 unit. But there, the demand is that we should have a CPAP available in such units. So India has done newborn units target, but CPAP is just, being scaled up. CPAP is not yet available in all units. CPAP is continuous positive, pressure for respiratory support. So even now, many district level SNCUs are very crowded. So we could see 2-3 babies to a cot, a newborn bed, newborn cot. And that crowding has happened because Government of India actually, alongside this level 2 unit, the program has been focusing also on level 1 care in subordinate hospitals. So there has to be a newborn stabilization unit. For a district level unit, at least 5-6 in the catchment area, there should be stabilization units. And every birthing unit where deliveries happen should be a newborn care corner. Newborn care corners and newborn stabilization units are still to catch up. So since those are not very functional and operational, most of the babies land up in district level hospital, therefore overcrowding, with compromise in quality as would happen. It is unfortunate that our hospitals in India, as much as in other countries, the global data was that 60% hospitals do not have adequate water, sanitation, and hygiene infrastructure. So therefore, there are several district hospitals where sometimes there is a challenge even to have basic amenities. So government and the people are struggling in that respect, the infrastructure and the basic amenities. And then HR is always a problem. India has less because pipeline has improved a lot. But we have other issues of, recruitment for those district and sub-district level facilities, and then retaining them. Retention is a huge issue because, the life support for a human being is not up to the mark. So many specialist pediatricians would not want to stay there. There's nothing for their children. The education is not there. The safety issues, the overall, urban facilities and provisions, which they are used to, are not easily available in those settings. And the professional satisfaction is also a little less. because they can do limited stuff. They have learned a lot. So those retention issues are there. People don't want to go there and go there to then want to come back. And nurses are always rotated. Nurses are posted, but hospital superintendent, is always struggling to take care of other parts of the hospital. So the neonatal nurses are then taken away. But I can imagine in other countries where even pipeline is not adequate, this must be much more difficult. So without warm bodies and working hands, newborn care cannot be delivered, even if equipment was there. But equipment management, the maintenance is a big issue. Still in India, in Bangladesh, in Nepal, we are catching up with biomedical engineering backup, but still an issue. So we have done a lot. We have exported the success. We still have challenges to meet, and we should be ready to roll out a little bit more concrete action. So to do what we are doing better, but also be ready to bring in more advanced care, because epidemiology is changing. So Shelley, what has happened is when we started newborn care, 50% of under 5 mortality was newborn causes. And our top 3 causes were in this order: infections, asphyxia, and prematurity. Over the years, I have seen this first 3 causes, the sequence has changed. Now, newborn mortality is easily 60% of under 5 mortality compared to 50%, because other causes of under 5 mortality have been controlled through vaccination program, through diarrhea. We have done much better in diarrhea, control. But the causes of death also have changed. Prematurity is the top. India, 41% mortality in newborn coming from preterm complications, followed by asphyxia and then infections. So infections have gone down. But the fourth cause, in fact, in some of my countries in the region, birth defects is the third commonest cause. So congenital anomalies, birth defects, which can be fatal, is coming up because the other causes of mortality have gone down. So proportionate terms, birth defect is becoming a very, high. So we need to prepare. We have to have surgical facilities. We have to have extreme prematurity care, some, technology, surfactant, ventilators, more and more. So parental nutrition, so a lot of stuff. So our advice to countries has been that while you are sustaining the gains and doing an equity stuff, because many states in the country, in India, newborn mortality has shown a good reduction over the period. From 1990, there is a 65% reduction until 2 years back. So neonatal mortality has fallen, and India will reach SDG target by 2030. But there are some 6 or 7 states where mortality is quite high. So we have Kerala, where mortality is 4 per 1,000, which is as good as Scandinavia. But then we have states where it is 28, 30, or even 31. So that India has to manage that inequity, and then quality of care. Coverage has been, great. The whole MDG period was spent on coverage. The Millennium Development Goal, and all countries did well. India did well. Therefore mortality has reduced. But to accelerate further, I think quality of care would be great. And then we have to also do some high technology intensive care availability going forward. That's future, but we should be ready. So what I'm suggesting is that countries have to actually do basic things right. Essential newborn care for all babies, that would start from good care of mother during antenatal period, good quality institutional delivery, essential care at birth for the newborn, then the postnatal care, additional care for preterm, additional care for sick babies, home-based care and newborn care and combination. And India did reasonably well to adopt all the WHO supported evidence-based recommendations in time. So my role in WHO later on was to bring the evidence from global to the region and help countries to implement. So research also was carried out in some of our countries, but largely it is the work of the people in Geneva, our WHO headquarters, and the regional office where I was sitting. We were bringing the evidence to countries and converting research into policy. So I remember, I called a regional meeting for our high priority countries on KMC. KMC research was being done, immediate KMC, which is keeping mothers right from birth inside the newborn unit. That research was conducted in India and in three countries in Bangladesh, India, and three countries in Africa. Results were available but not yet published. So I said, why lose time? I brought 6 countries and we gave them the evidence that this is emerging. Be ready to implement IKMC, for example, KMC overall, in hospitals, at home, community initiated, home initiated KMC. Evidence was already there. So that's how we, supported countries to adopt the evidence-based practices, which were coming regularly from the global process. And therefore, with all of that, all countries have to take these steps, that they do home-based care, newborn care, closer to homes, level 2 care at district level, and also basic care in the subordinate health facilities, but also top up with intensive care as the resources become available, the skill set becomes available in countries. So then this is the progress, this is the trajectory all countries should follow. And then we will talk about quality of care a little bit later, if you have some clarifications to seek so far.
Yeah. Thank you so much for providing that conceptual and contextual roadmap for improving neonatal mortality rates. You talked earlier in that bit about how just having skilled birth attendants and essential newborn care kind of helps to do that first big drop in neonatal mortality, and then after that it goes into the more specialized care, the level 2 care, and scaling that up. And then once you get that, then you start having the concerns with quality and ensuring that you're doing, you're having high quality care as well. And so that kind of comes as I don't know if it's the third layer in everything, but it seems like a good part of the discussion to kind of talk about quality, because that's, I know, one of your other areas of interest. And I'm curious as to, when did that interest in quality develop? Is it as you saw, okay, we've scaled up care, we have all these level 2 NICUs, but now we have overcrowding and now we're still having high mortality? Where did that interest come from?
This was observation which was common to many of us, that there is a problem with quality of care in the pediatric practice. For example, I remember I was still with the government in my clinical, lifetime, and WHO had a regional meeting on pediatric hospital care improvement in 2007 and 2008. So there were some remnants of those, considerations, that pediatric care, IMCI, Integrated Management of Childhood Illness, was launched in 1995. And many countries, there were at least 120 countries finally, 120 where IMCI was introduced, but 1995 countries actually scaled up the IMCI. IMCI was a great instrument to assure a good quality care, a very standardized care for common illnesses which are cause of mortality and morbidity for under 5 children. Now, IMCI actually would mean that if we did it well, would assure reasonable quality of care for people in the homes. but it wasn't happening that way. So there was a realization that we should do a little more, and more tools were emerging. We had a pocket book of child care in hospitals. That's a famous pocket book, blue colored, now in third edition, where we have described, WHO has described how to manage in small hospitals common pediatric illnesses as a inpatient treatment. So the standards were getting available. IMCI was standardized, pocket book was standard. There was a pink book in WHO on managing complications in newborn. That was again vintage of 2004-5. So with that in hand, 2013 actually we did the first regional, when I was part of the WHO CERO. We held a regional meeting on quality of care for reproductive, maternal, newborn, child, and adolescent health. So 2013, and we started working on a framework of quality of care for RMNCH. And finally, we, with the help of member states and the experts from the region, we were able to publish a regional framework for quality of care for RMNCH in 2015. And while we were doing, we also had access to some facility assessment tools, quality of care assessment. So we had the benefit of applying those WHO hospital care assessment tools for pediatric and maternal care in several countries in the region. And we had reports to say that there were gaps. There was sufficient quality in some aspects, but insufficient quality in many other aspects. So we had an assessment tool also finalized. We had the framework. The framework suggested actually 7 steps in 2 blocks. The framework suggested that we should start with the national policy on quality of care and a national strategy and a national unit. Since we were from RMNCH community, we were focusing on our area of work, not on surgical care or orthopedic care, but RMNCH. So therefore, we said there should be a national structure to support quality of care, and there should be adoption of standards.
Sorry, Dr. Rajesh,
care
could you
for
please explain RMNCH for our listeners? They may not know what that means.
So that's a course of reproductive, maternal, newborn, child, and
Got it.
adolescent health.
Okay.
So that, although our focus has been until now on maternal newborn health within RMNCH, but the system readiness was to be there. So we said the community moves forward. This was 2013, 2015, we had the framework and the assessment tool, where the framework was saying you do some national level scene setting, that there should be structure and mechanism to improve quality of care. But it also said that there should be simultaneous action on adopting the standards, doing some assessments, and immediately starting quality improvement at hospital level. So basically 2 buckets of work. System level strengthening, right from national and subnational level, and then hospital level strengthening and improving the quality of care at the cutting edge, where the service is delivered. So this was ready. And then fortunately for us, the Global Quality, Equity, Dignity QED network started. In 2017-18, while we already had published our framework and started some inroads into our member states' policies of quality of care, QED was a big push, the global framework. There were 7 countries from Africa and 2 from India, from Asia, India and Bangladesh. A network of initially 9 and then 10 countries. and 2 from our part of the world. And that gave us a little bit more thrust to present to the countries in the region that. And by then, Mobuzo, what happened 2018, we had a Lancet high level commission on high performance systems. And there they clearly analyzed and said that more lives are being lost because of poor quality of care compared to excess of care. So that's clearly suggested that people were able to come to the hospital, were coming to the hospital, but we could not make them survive because quality was bad. So there was twofold problem there. We are not saving lives, we are not reducing morbidity, but also the trust of community is reducing. So they will bypass small hospitals and come to big hospitals. They will bypass government hospitals and go to private hospitals in the hope that there is better quality there, although it was never sure whether they will get good quality even in private hospitals. Private hospital may be clean, maybe a little bit better equipped, but nobody knows whether quality of care actually delivered is as per the standards. So that evidence was there. We had some pieces ready. My then, job was in WHO at that time to actually convince countries that while you are setting up the system, let us start moving at the quality improvement at the cutting edge, at the point of care. So therefore, we coined this point of care quality improvement strategy in the region. That healthcare teams can actually come together and should consider that quality improvement or providing good quality of care should be their business. It's nobody else's business. It's the healthcare teams who have to improve the quality. The problem is when you do a lot of quality assurance work, we start accreditation, for example, or certification exercise. People come to hospital, they visit, they assess you, and then give you some ranking and then go back. So it looks like that quality is somebody else's business. They will take care of this. So let us continue to do what we are doing. But we realized, all health workers actually want to do their best. It's not that they don't want to do this. Many times it's the system which is not allowing them or is not promoting them to actually provide their best to the patients. So it's not about the people in the system. Somehow they have to be mindful of how system is helping them or not helping them. So we picked up some of the models which were very, which had a history, IHI, which is based in US. They have been doing this, quality improvement stuff for 30, 40 years. In Africa, for example, we have models of, the drivers of quality, the change ideas. So all of that is well known, and then the Japanese methodology, which came from industry to healthcare, 5 Sigma, 6 Sigma, total quality management. So all those, those jargon was available, tools were available, but our contribution in the region was that we simplified it. We simplified it to be able to be used by the frontline healthcare teams in resource poor settings. Our premise was that all health workers want to do good things. Secondly, by now, when we started, 60-80% hospitals were reasonably well provided. Infrastructure was there, health staff was there. Shortages will happen. In LMIC countries, there will not be a day pretty soon that everything is available everywhere. So some restrictions would be there, but they are reasonably provided. And without asking for additional resources, healthcare teams should be able to make some improvement. So our premise was they want to do good in life. The infrastructure is reasonably well provided, And the only thing is they have to be careful, mindful about the process of care. They have been trained, they know what to do, but they are stuck somewhere that they are not able to practice that evidence-based care. So the point of care quality improvement is basically a problem-solving approach, which is 4 steps. Now, if you compare with other models, there are 7 steps, there are 8 steps, there are 10. But this was simplified. Of course, it's a very primer kind of. It's not a proficiency course and quality improvement. It's a primer for people to start, dirty their hands, achieve early success. A little bit of leadership emerges. The healthcare teams get formed. They start using local data to identify the problem. Then monitor that data to document the improvement, and then sustain the improvement. So what do we suggest to them? Come together, try to see if there are any issues of quality. If there are multiple issues, try to prioritize, and we provide them some tools to do that. And then we say, you please analyze what is causing this problem. So for root cause analysis, other set of tools are there. 5Y, inquiry, or fishbone, analysis, Pareto principle for, understanding how to prioritize. So small, skills based on management science, quality improvement science, problem solving. So identify one, use the root cause analysis, then as a team decide what solutions could be there to address that issue, and start with one solution. The training is that start with one, although you could do 2 or 3. You could also do 2 or 3 quality problems at once. But for training purpose, we said you start with one solution, and do a rapid implementation cycle, decide the indicator and monitor if it is working or not, the change idea, the solution. So PDSA, and then try to see if it works, sustain it. So early success. So, the healthcare teams, when we invited the first time in my regional training, we were careful to invite the hospital director, a midwife, a pediatrician, and an obstetrician, because we were starting from maternal newborn care at the time of birth. Because maximum lives, we were told by evidence, are saved if you improve quality around the time of birth. Therefore, we started there. We made a choice that we will start from here. Therefore, the obstetrician is important. Therefore, pediatrician is important. Therefore, midwife or a nurse is important. But the medical superintendent or the director of the hospital, because he is the one who is accountable for overall quality. They should all be trained together. And Shelley, we also made a strategic choice that we will start with the clinical leadership and nursing leadership. We could have started from the field, but we thought we should actually keep the profession with our, inside, and clinical leaders must be converted. And once they are convinced, this knowledge will percolate down. So we started with medical schools, then we shifted to district hospital, and in some places we actually went down up to community health worker level to test this 4-step model. So we have success stories from medical school setting, on maternal care in labor room, in newborn care in newborn units, and then in many hospitals it diffused outside the MNH care area. Some of the surgical teams picked up. We have seen projects using point of care quality improvement. We call it POCQI, POCQI, to reduce pressure sores in surgical ward, for example. In obstetrics, of course, partograph, surgical infection reduction, IV line. Surgical units also did IV line, infection. Cardiology department introduced this, and they improved the time period between arrival in the casualty or emergency room with a pain chest and the ECG done. So the time taken initially was 40 minutes, but after the POCQI was introduced, it got reduced to 12 to 16 minutes. So they could, cut down the time by improving the process of care. Waiting time in pharmacy reduced. Waiting time in operation theater. Now, newborn babies with ROP, they have to be screened and brought to OT in big hospitals, where general anesthesia and detailed examination and treatment. So they changed the process of care, and they could reduce the crowding and also reduce the waiting time in the OT using this problem-solving approach. So we demonstrated that it works at the front line, it works at the top line, and it promotes local leadership. It promotes teamwork. It promotes, use of data for improvement. And it can be done without additional resources in the beginning. So our advice was do something, show the improvement, take that improvement data. There is a visual run chart, whiteboard displayed. KMC duration improved. The mother's own milk use improved. Oxygen use has decreased. Antibiotic use has decreased. So we have done all of those projects using POCQI. Now you take this data to the superintendent and go to the district collector or the district CEO and tell them without additional resources, we have improved the situation from this to this. The breastfeeding in 1 hour has improved from 30% to 80%. If you give me a counselor now, additional working hand, I will make it 100%. And the district management readily agrees. So these buggers have been doing pretty hard and they have already shown improvement. Why not give them additional hand? So if I had gone there with the first time and say, give me more nurses, give me more, nobody agrees. So I said, you start improvement, show improvement, you will get more resources. So we have done that. So point of care quality improvement has 3 sets of packages. One is for training the healthcare teams. The second is to provide post-training hand-holding support, coaching in quality improvement. And the third, document is how to run this in a district as a program, not just as a training activity. It's not just POCQI training. They have to do actually training, but post-training and then monitoring, and then collate the data and then start doing collaboratives on improvement. That we have common problem in these 5 hospitals. Why don't you come together, learn from each other and do a common quality improvement project? And then it becomes a part of work culture in the district if district system starts engaging and supporting this. So that's the vision. And this was quite useful in our countries in the region. China, actually, UNICEF helped us to take it to China. They translated it in one province. It went to Kazakhstan, again, because we had partners. This POCQI package was supported by WHO, of course, but UNICEF, UNFPA, and USAID. And then it was taken through QED network to the global toolkit. And in Africa, I think they have also used it, and maybe they have done a French translation also. So quality of care for me, became a second life. We were able to demonstrate that a simplified approach is possible, and we don't have to endlessly wait for system to get ready. Governments are already investing. They will take time to reach the bottom. Why not start from the bottom? There is a top-down approach, there is a bottoms-up approach, and the system would then strengthen around it. And without wasting time, let's do some action at the point of care. So therefore, point of care quality improvement. So what has happened while it got recognition, the governments have started looking at, for example, India, they have introduced POCQI as a principle in the training package of SNCU training now. When they are revising the SNCU training package, POCQI is already sitting there. That you train them, but also train them in quality improvement. So clinical training plus quality improvement training integrated. So though you don't have to bring them back for QI subsequently, but tell them, go back, you have learned new thing, and go and check whether you can actually put that into practice. If you cannot, use POCQI, and you will find how to put into practice what you learned. So global midwifery educator program, they have included POCQI already. Global ENCC, the essential newborn care course, which was launched 2 years back, they have also included point of care quality improvement as a component of each module. So going forward, when they do small sick newborn care training package, I think they will use quality improvement. So integration is happening, that clinical training plus quality improvement training and plus supportive supervision later on, which I am saying QI coaching, but that's largely countries are used to supportive supervision. That should happen after each clinical training. Clinical mentoring should happen. After QI coaching should happen. But it's essentially supportive supervision through which mentoring is offered in post-training phase so that health workers can actually start practicing what they learn in training. So newborn survival, somewhat achievements are there. Next tranche of improvement in mortality will happen because of quality improvement. And third, I think we will still need technology-based solutions for two reasons. One is to reduce inequity, but also be ready to higher level, even level 4 level of care, when more extreme prematurity will be the cause of death, when birth defects will be the cause of death. Congenital heart disease would be killing newborns. So we have to get ready for that. So I'm not saying today. We have taken 2 decades in India to scale up SNCUs from 1 to 1,000. So countries will have to follow their own contextual, progress. They will run into problems of infrastructural readiness. They will run into problems of human resources. They will have to be careful about the budgets. They will have to be careful about the essential equipment and supplies and a constant quality improvement and monitoring. And not to forget, India also actually, Mabuzo went a little bit ahead and started addressing the upstream determinants of newborn mortality. Adolescent pregnancy, when we found 10% of pregnancies were adolescents and newborn mortality was 1.5 times higher there, the government of India actually paid attention to address the health and nutrition of adolescents and preconception care, health and nutrition of women before they got pregnant. And family planning, of course, such a huge, advantage for child survival. And we found in a study in Bangladesh, 53% reduction in maternal mortality coming from family planning. So countries have done well. They have done hardcore newborn care, but they have also not forgotten maternal care component, because half of the newborn deaths happen because of maternal causes. And then upstream causes they are looking at. So education, employment in Bangladesh, for example, has postponed pregnancy, postponed marriage. So child marriages have reduced. Adolescent pregnancy has reduced. Adolescent birth rate is going down. So we have done well. So countries in our situation in global south have to learn from each other. Maybe start small, gain incrementally, look at the overall big picture and learn from each other. And we can do it.
Yes.
So India is poised for newborn SDG. So are 8-9 more countries in my region. Only one country, 2 countries might miss it. out of 11. And 11 countries in my region, Southeast Asia, 25% of world population lives here, although there are just 11 countries. And we have a little bit disproportionately higher burden of poverty and disease. So I think if I do global calculation, 25% population, but we are responsible for 28% of burden of disease. So we are a difficult population. So a lot of inequities are there. So I think countries will do better if we learn from each other. So that's my ringside view. I have contributed a bit, but I have been there in the journey. And we must admire the commitment of the governments and the partners who have delivered this.
Just wow, Dr. Rajesh, you touched on so many interesting things, and I don't even know where to start from in terms of like what to unpack from what you said. But I just want to say I really do appreciate you saying that we can start from just asking the questions. I think that's something that clinicians from LMICs tend to forget, that just ask the questions and start with the low-hanging fruit. You don't need big funding to just start from the quality improvement, POCQI interventions. So I really do appreciate that insight. You have thoroughly explained what POCQI is, how POCQI can help, and what POCQI can do. But I don't think you've touched on how people can actually access this material and also get linked to the trainers and the champions like yourself. So could you please give us a little roadmap on how someone from Lesotho or Ethiopia can get hold of this information and start doing some POCQI projects in their hospital?
Sure. We have a digital version of POCQI also available. There is a initial 4-hour self-learning workbook kind of, introductory course available in WHO Collaborating Center for Newborn in Delhi. On their website, the WHO supported that course is available. Now I am helping IPA, International Pediatric Association, to do a similar course available at their platform. So Indian International Pediatric Association has more than 150 national associations as their members, or nearly 150. And all pediatric associations will have access to POCQI. I don't know whether they will use the same name, but a QI introductory course. And then, the actual POCQI materials are available on WHO website, in the Southeast Asia Regional Office website, but also in the QED toolkit, the Global Quality Equity Dignity Network, which I think may have stopped by now because of funding issues. But Healthy Newborn Network website, I think they also carried that. And I'm not sure Nest 360 also would have this because I had shared with them. But I will certainly in follow-up send you the links where these materials are available. The POCQI training manuals, the QI coaching guide, the district implementation guide, and all of this, is also supported by globally developed global tools. So we should use all of that. If there is a national policy quality strategy document from WHO headquarters, so that's the overall national. We have a regional framework from Southeast Asia Regional Office. Similarly, other regional offices have different approaches. So quality improvement, POCQI is just one small piece. There are other approaches. For example, we ourselves have followed MPDSR beautifully, maternal perinatal death surveillance and response system, to identify what led to the death of a newborn and a mother, and what are the quality improvement triggers in that diagnosis. And then POCQI can come in and improve the situation so that we don't have a next death because of same problem. So you could do death reviews, you could do clinical audits. Of course, quality assurance accreditation program is helping to set up the national infrastructure to to ensure that quality standards are met in terms of infrastructure and processes. But improved clinical performance, many accreditation programs don't have that component. So improving in quality of clinical care, which happens through POCQI by the healthcare teams, uh, could be one additional element, even if accreditation has happened. So we have to bring those pieces together. But my thought was that healthcare workers should actually start something which is within their hands to actually start improving. So therefore, POCQI. So the materials would be available readily. Online training course is available. We have actually facilitated or a asynchronous and synchronous digital program, converted 2 days training into a digital format. That also is available in another network which we had supported from WHO. So it is easy. One could self-learn, but also access some community of practices. We have one in operated in from India. That community of practice can be useful for providing facilitators also to do the training. So I will send you all the details. There is a publication in regional office from WHO which gives the history of implementation of POCQI of first 5 years. So there is a documentation that how did it start, how did it expand, and what were the gains, and what are the common projects which people have delivered through POCQI. So that document also is available. So people can access that. It's in public domain. So I will send you the links.
Great. Thank you so much, Dr. Rajesh. We certainly learned quite a bit about how we can start improving neonatal care wherever we are with whatever we have, starting simply and moving forward and getting more complex as the situation requires it. But we don't necessarily need to start with the complex. We can start simply and move from there. So thank you so much for that. And thank you for also highlighting the changes that happen as you improve neonatal care. And sometimes I feel like we forget that because we see neonatal mortality getting better, but then we start seeing different causes of mortality. And sometimes it's easy to think, oh, we're not doing enough, when it's just par for the course. As you get better at infection, then something else becomes the leader that may not have been counted because those babies died before. So it's not that the care isn't improving. It's just that we're changing the landscape. And so you talked about that early on, and I just wanted to highlight that because that is so easy to sometimes forget, and you miss the wins that you're making when you see these changes, and it's just part of improving efforts. So as we wrap up today, can you share some words of advice for those persons? You shared a lot, but I don't know if there's anything lastly that you want to add for somebody who's trying to make improvements where they are, any words of encouragement, and then let folks know how they can connect with you.
So, what I suggest to them is that, we are all trained to do good things in saving lives. All of us have received some basic training, and we can fit in. So we should never give up. It's our job to do the best. And if I keep myself a little bit motivated, one is, internally I should decide that I will do my best, which many health workers already have. Keep your local leaders with you. When you start quality improvement, your next in line supervisor, you keep her or him with you. Secondly, form a team. In our healthcare systems in many countries, Shelley and Muguzo, the hierarchy is very strong. Medical profession, medical officer considers he is the top. They don't give a damn about midwives, nurses, and there are, ward boys, janitors, But we should realize in a complex business of saving lives, we have to manage a complex health system and where each one has a role and all of us are equal. So consider an advice or a suggestion or a change idea from a security guard or a sweeper whose job is to clean on daily basis to improve the part of the care where their role is direct. So a leader can be from the nursing side in the healthcare team who is doing quality improvement, and I have seen nurse leaderships actually perform much better, even better than medical profession. So we must actually empower nurses and midwives proactively, and then don't discount the value of a janitor or a person who cleans, because they know what can improve the situation much better than the nurse or the doctor when it comes to hygiene. So my request is, don't give up. We can make a change. Keep the local leadership involved and perform like a team always. And last, patient and the family are equal partners in healthcare. Many programs are pretty weak in involving community or patient groups. In our day-to-day practice, I think we are reaching the third approach of quality, which is co-production of health. We as a profession and the patients and their families are together responsible for making health and maintaining health. Therefore, healthcare service also depends equally on the patient and the community, patient themselves if they are grown up, and the healthcare teams. So those are my advice for sticking to basics. And many of these things we actually learned in our medical schools and nursing schools, but during the practice, because of the system issues, because of the several constraints under which we work, we have not been able to practice. I think we learned many of these things in our schools. So it's time to proactively pursue and keep system with you so that we can deliver.
Thank you. And I know that there are some folks who are listening who would want to connect with you. What's the best way? Is it through email? Are you on social media? What's the best way for someone to connect with you if they want to move further, maybe possibly collaborate or even just learn a little bit more about what you do?
So email is the best, of course.
Okay.
I have social media appearance, but I don't usually frequently use that. But of course, email we could share, and
Great.
People can.
Perfect. We'll put those in the show notes as well as the links to the POCQI resources that you'll send us, and anything else that you feel like we should share with those listening with us. Thank you again for your time. We certainly learned a lot.
Thank you. We didn't realize it's been a long 1
but
hour.
It's been a very
so let's see
a very insightful one. So thank you so much for sharing your wisdom and your learnings. And I'm sure many people leave this chat very inspired to do something in their settings.
Yes, definitely.
Thank you so much. It has been a pleasure, and I also was able to recall with pleasure what we have.
Yes.
Thank you.
Thank you. And to everyone else listening out, we will see you next time on another episode of the Global Neonatal Podcast. Thanks. Bye.
Bye.